Here we go. Hey everyone, Kevin, Sean, and Donna from RPH Ally. So love having you back here. For me, it's great being back. Excuse me. I've been visiting a friend this week, and then kind of a tough week for me. So I just love seeing the smiling faces on these two. And when we were putting together the program for Donna, that will, for the Deprescribing, I like thinking about how many times as a pharmacist have we had those medication profiles that just make you cringe, right? And we all want to do something about that, but we really don't know how or the best method to do that. And a lot of times it's not taken the right way from the prescribers when we try to get into their business. So Donna, I'm going to kick it over to Kevin first, ask you the first question, but thank you for hopping on with us today and on this launch announcement. So
yeah, awesome. I'm excited. Thanks.
Yeah, no, it's super excited, Donna. You know that you and I could totally geek out all the time because of our kind of geriatric background. And I love the work you're doing in general and the way you're kind of moving the profession. We even laughed about, some things and just how small the world and space can be. And I am going to start calling you the Donna Bartlett kind of moving forward because I love it. Like, you've innovated the space. You've done tons of wonderful things in it. I know you're very humble about it, which, I certainly appreciate. But I'm also really thankful that you came and joined us so we can start bringing some of your knowledge and leadership to the rest of the pharmacy world. So first things first, how'd you get there, Donna? Like, why? You could have went to all these other specialties. You could have done all these other things, but you decided Deprescribing in this kind of world was where you wanted to dedicate yourself. Can you hear more about that?
Sure, of course. So, it's funny because I remember thinking gosh, geriatrics, everyone loves to do the cardiology and the emergency medicine and things like that. And there was the comment it's really not very sexy, which it isn't. But you know what? The whole world's getting older. So we had to, move forward this way. And I always try to stay in front of the wave, if you will, of pharmacy and realize that all of my siblings are baby boomers and I'm not. So I have to be able to help them out. But no, really, in all seriousness, people in the community are older adults, and the majority of people who came to the pharmacy through my interning years and people that I studied, that many of the patients were actually, geriatrics, and just seeing the over medication of them, I think just really made me love the sleuthing, if you will, of trying to figure out what they still needed and what they don't need anymore. So just trying to help them out and have a voice. I think our older generation just doesn't have the voice or can't find the voice to ask because I'm not going to ask the questions type thing too. So it was really important to me when I was going around and doing the outreach programs and trying to help out older adults and just seeing similar things happening over and over again and falls and all this other poor, bad stuff that's happening to them, hospitalizations, and thinking this can all be prevented. So we really started off with geriatrics, and it moved into deprescribing because medicines are working. They're making us live longer. They do their job, but our bodies are changing, and we got to get that message out. We have to let older adults know that, you know what? You did it. You've made it to this age. Now let's keep you healthy and upright and in the community. And that's really important to me to be able to do that for folks.
I'm so happy to hear it, Donna. I think that, Sean and I have talked a lot kind of off the scenes about, we hear a phrase often and it may be overused, but I'm going to use it anyway, like the brokenness of healthcare. And, when it comes to brokenness, you think that something isn't working, but that's not true. It is working. It's just functioning in a very inappropriate way. And so Sean and I, from our different perspectives, we've seen, those patients, and Sean mentioned before that they have 20 plus medications on board. And then I've seen them during the residency, or I've seen them in the hospital, and those same 20 medications, they go into the hospital with those and they end up coming out of the hospital with those. And then they come back into the hospital, and you're seeing it in your work every day. And so I feel like there's got to be a time, there's got to be a place to be able to stop that cycle and change the way we go about it. And so to do that, why did you feel like bringing your specialty, bringing your kind of knowledge to RPH Ally was a good fit in a way for us to be able to do that?
Yeah. So, it's really interesting. As you know, I wrote a book, Med Strong, Shed Your Meds for a Better, Healthier You. And just bringing that to people's attention I've heard people say, this is so important. I don't know about this. Friends and family, and then other care providers, not only pharmacists, but thinking about physical therapists and occupational therapists, dentists, and optometrists. We're all in this together, and we're all seeing, the older adults on all these medications. We hear it all the time. I can't believe the meds that people are on. And so it really is an issue. In writing this book, I took years of experience and put it together in this book to help people understand. But now what I'm hearing when I teach students about deprescribing, because I teach it on rotations for students. So they don't have it throughout their coursework necessarily. It's not a requirement to understand deprescribing, but they all say, this is so important. We need to know this. We need to understand this. This is so important for their practice. What you're teaching us, we've learned so much in just a short period of time, just because we're looking at these cases and learning about this very important subject. So when RPH Ally and talking to you guys, when I was thinking more and more about it, I'm thinking all the pharmacists that are out there now, if they haven't trained in deprescribing, yes, we might all know, yeah, this drug isn't probably very good. It's on the beers list. You probably dabble with it, but are you really looking critically at people's lists of medications? And I think if you don't mind if I share just one quick story about someone who was on 6 medicines, talked to me about his medicines. And I think anyone and everyone, and even me as a pharmacist in retail before I was doing deprescribing, would have said, oh, great, your cholesterol's finally getting lowered. And yet they were on 3 cholesterol medicines, and one of them changed, which became the workhorse. The numbers were finally working, but they kept all these other medicines on. And then there were some other medicines too that were not beneficial for this patient. After speaking with me and working with him, I followed up with him in a month. He had worked with his doctors after talking to me, and he went from 6 medications down to 3 medications. There's just a very simple story, and it's about cholesterol meds. It's not even the high hitters necessarily that we talk about, like anticholinergics and benzodiazepines and things like that we really don't want older adults to necessarily be using. But to see this and to see it work and to see his excitement, I'm like, there's so many of these stories. If it happened once here, it's happening in many, many places. So.
Wow, that's so true. And you're seeing so much more data come out, Donna, when it comes to how much does deprescribing actually help the entire medical system save costs and money and readmission rates or acute care statuses. And it's amazing, like even from a long-term care perspective, when I many years ago when I worked in that setting, how many of you mentioned the high hitters, like the benzodiazepines and the anticholinergics, even inside of the settings that you think like they're caring for older adults all the time and still struggling with things and still proliferating issues that are popping up because of very simple medication changes or eliminations, that could be done. You mentioned a little bit, before about, where is kind of the pharmacy world going? And I know that's a big passion of yours in general, teaching students and teaching physicians all the time about like what's important about medication education and what's important about, knowing more and being more skilled clinically. But you mentioned a study previously that I think really speaks to the data that I'm seeing on the financial side and kind of legitimizes it on the clinical side. Can you tell us more about like what we're seeing kind of in the pharmacy world and where we're potentially going?
Sure. So off the top of my head, I think it's called RAPID is the study. And basically what they are showing is that pharmacy positions might decrease over time, but really it's the pharmacy that we see now and that we know now. And we need to adjust to these changes. And part of that adjustment is a lot of med management and helping people through optimizing their medicines and getting off of these unnecessary or medicines that are inappropriate now for individuals. So there's that that's one area. And we know, like, with COVID even, and with vaccinations and things like that, that pharmacy is doing now, those are all new trades, if you will, of what we're doing. But the other side that we have to be looking at is what we know, and being the experts in these areas, and being able to look at medications critically, and being able to understand what the patient's needs might be. And they look very different on paper than when you start talking with them. One example, I was just doing a med review the other day, and it was like a 4-level prescribing cascade for this person. And when you first look at the medicine list, you'd probably be like, you know what? Yeah, they probably need all of these things. But then once you speak to them and you learn about timelines and how long they've been on these particular medicines, and then when they were added on, you can see the cascade occurring. So, so having the time and the expertise in order to do that is important. So what's important about this study is, how do we move forward? And these were all of the, big hitters, if you will, high hitters of healthcare policy that were basically interviewed for this study, and people in healthcare or pharmacy organizations, I should say. And I think what we need to be thinking about is, how do we get paid for what we're doing? How do we get paid for this knowledge? We do way more than just dispense medicines. And I don't mean to say just dispense, but we do more than dispense medicines. And in order to show our worth, we can see it through the deprescribing. We can see it through benefits. People are improving their frailty scores with less medicines. They are in the community. They are able to recover and have less cognitive issues and be viable folks in our society. So we really need to be thinking about the optimization and the health of our older adults, and how, optimizing medicines can do that for them.
Everything from venture capital and investment funds, Donna, are really pushing kind of the entire world toward ambulatory care, toward home care, right? And trying to keep them out of acute care kind of settings. And so we're seeing those investment dollars. And I know that all three of us here, and anybody listening or that listens to this afterwards, all agree. If you're a pharmacist, you know that there's one profession that would be really good at helping people avoid a lot of those acute care settings, and that's us. But here's one funny thing that you and I hear every once in a while, I know Sean does too, is, but the robots are just going to replace us, Donna. Like, we're just going to have, there's not going to be any money in it, or for me to use my cognitive skills or my high level skills, because I'm just going to have something, a machine, be able to look at a med regimen and kick out the perfect way for an individual to live the rest of their life. Any thoughts on that, Donna?
Yeah. So, everyone's an individual. And I think that that's the part that we almost forget. Like, and you hear this from physicians too. They go by the algorithms. They go by the guidelines in treatment. And if they don't, then they don't get paid, basically. Like, there's this whole insurance side to things, and payment. And are you doing everything that you're supposed to be doing? But unfortunately, a lot of those guidelines do not have information for people who are 75 and older. So here we are stuck, right? And we got to look at the individual. And I say this all the time to the students and to the providers: when you're looking and seeing a patient, and you got to think critically, right? You have to be going, okay, how might this drug affect this person that just fell? What are the issues? So you're looking at their medicines, and you're checking electrolytes. There's so many checks that you have to do. You have to be checking arrhythmias and QTC prolongation, and so many factors. So two people could have exactly the same meds, and one person might be perfectly fine on them, and the other person might be in the hospital due to a fall, because they are more susceptible to these particular side effects of a particular medicine or group of medicines. So, and we can see that anyways, like side effect profiles, right? It's a percentage of people who have this particular side effect, but older adults tend to be more susceptible, especially to cardiovascular, central nervous system type of side effects. And depending upon somebody's frailty and cognition and abilities, that is also going to be a factor. So,
that's
yeah.
Perfect. I think that honestly, like those cognitive skills you're really mentioning, like us looking at connecting multiple dots, like it's not you've got 3 things to be able to recognize. Like you have a whole myriad, a cornucopia of information that you have to be able to consume, digest, and then deliver back to your patient based on a very personalized regimen. And everything out there is personalized medicine. I mean, Sean and I also participate in another company called PGX Ally, focused on personalized medicine utilizing genetics. So it's just there's another piece of the puzzle that we have to be able to incorporate, and make sense of patients that we're not going to be replaced by robots anytime soon. But what we will be replaced by is robotic thinking, because that's where we have to be able to break away. And I think that's the deprescribing mindset, Donna, that you have, pushed out there for people to be able to recognize. And that's why I'm so excited for you to join our PH Ally. But I'll kick it over to Sean for our kind of last question for you on.
So this one, Donna, like, so I just spent a couple of days with a couple friends that, I haven't seen in 10 years. And we were all part of the same chain pharmacy we worked at. And, and so it was hard not to like just talk about pharmacy the entire time. Of course, we got caught up with that, but me being, with our PHLI now, and I'm so curious, like how it is there. Is it any different? Probably way worse than it was when I was there. But so when you talk about like what to expect in the channel, I kind of want to add a little bit onto that as far as like, what do we expect in the channel, and how would I get my 2 buddies, Mike and Mo, who don't have this type of vision, but like, how do we get those 2 guys to come in here and get involved and just kind of like take this to heart and be like, you know what, I can do something about this. Maybe not today, but I can learn and then transition type of thing.
Absolutely. So, we already touched on a few things, the polypharmacy side, deprescribing, and the prescribing cascades. And that's just the first 3 weeks. So I have probably about 40 different topics we can talk about in regards to deprescribing. So, various things to come, the triple whammy, for example. Do you know about that one? And that's so common. People end up in the hospitals because of acute kidney injury with that. Thinking about maximum dosing, it changes as we age. So there's some medicines that we just cannot be prescribing at the same level, yet people stay on that because they've been on it for 20 or 30 years. And it's not thought of that, this is an issue. Talking about barriers, patient barriers, and physician and prescriber barriers, and what's going on there, and how do we move through these? How do we get people to have these conversations, and what questions do we have people ask? I've heard so many people say, especially older adults. I have my list of my favorite things that they say. But there are things such as, "Oh, I don't take any meds." I'm like, I bet you know someone who does. And then other things like, "Oh, I only take natural medicines," or "I only take vitamins." But you see like these huge lists. Everything counts. Everything matters. So we'll be diving into those things too. One of my students did this whole rearrangement of an independent pharmacy based on deprescribing in the OTC medicines that can be deemed a little bit more dangerous for older adults. So let's put those right in front of the pharmacy so the pharmacist can see who's grabbing them. She tagged all the different high-risk medicines so that when people at the store were bringing them out, they said, "Hey, you might want to talk to the pharmacist about this," because there was a colored dot on the product. How cool is that? And stop signs that were just like, "Hey, stop and talk to the pharmacist. This might not be good if you're 65 or older." Very simple things. And kudos to the pharmacist there who said, "Yeah, do this," the owners. So things like that. We're going to be talking about the Lone Institute, the think tank, and oh my gosh, they're awesome with thinking about deprescribing and over-medicated, and just all different types of medicines like proton pump inhibitors and why we care. And I know a lot of people know this, but students are always surprised when they learn a little bit more.
I love it. No, that's amazing. It sounds like it's going to be very active, very busy, lots to learn. I love it. I love that you even brought in an independent pharmacy, like really changed the way they manage a pharmacy based on your teachings. I love it. That's all I needed to know right there. Good. Awesome. For everybody watching, if you want to get plugged in to Deprescribing and join our PHLA, at rphla.com. Join our channel and get plugged in. So thank you for joining. We'll talk soon.
Thanks so much. Thank you,
Thank you
Donna.
so
Talk to you guys
much.
soon.
Thank you.